You can hear me in the back? We're going to talk about defining and measuring death today. And it's actually one of the most important jobs a doctor has in our society. You're not really dead until the doctor says you're dead. So there was a time when doctors weren't very good at diagnosing death. And people were quite afraid of being buried alive or cremated alive or whatever. And there were, today you read every year there's one story about somebody waking up who they thought was dead. But it used to happen a lot more. And many people think that some of the rituals around death were actually ways of making sure that the person was dead, like putting them out on the kitchen or the dining room table for a couple days, wailing, wake them up if they could be wakened up, very elaborate rituals of washing them and swaddling them in cloth and so forth. But in 1812, the stethoscope was invented, and we understood a lot more about human cardiopulmonary physiology, and doctors got very good at saying that people were dead until technology actually caused a problem with determining when they were dead. And we're going to talk about that this morning. There are a number of important cultural behaviors which are associated with death. For instance, mourning and grief begin. The person is gone. Patient in the hospital is sent to the morgue. They're not kept in the hospital room. Obviously, there are things that you can do with, and it depends on the culture and the religion, about burial and cremation. And even if it's leaving somebody on a hillside to be eaten by the birds, that's an important part of a culture. And you don't do that to living people, you do it to dead people. Inheritance begins, health insurance stops, life insurance begins, and actually there's an issue of you're not dead, you can't be charged with murder until a person is dead. And more apropos of what we're going to be talking about today, there are various medical behaviors that are associated with death. Treatment stops. Anatomical dissection can begin. Your cadavers are all dead, I hope. Autopsy. Practicing techniques such as endotracheal intubation. I think it's done much less now than it used to be, but it used to be a common practice when somebody died in the hospital or the emergency room to call a student in and have them do put an endotracheal tube in, do an arterial, put an arterial line in and stuff like that, without asking family permission. And then the one that really is driving the discussion today is removing organs for transplantation. So this is a polio ward. When I was a kid, this was high technology. These were iron lungs. So people were in them. It's a pressure chamber that's sealed. Their head is coming out, but there's a seal around their neck. And at the bottom is a bellows that inflates, and when it opens, it sucks air into the, or when it closes, it sucks air, creates a vacuum in the chamber, and it sucks air in through the person's mouth and nose. So it was a negative pressure ventilator. This was when I was 7, 8, 9 years old. This is what there was a big polio epidemic in the United States, and kids were ending up in iron lungs and worse. And we were all scared. Our mothers wouldn't let us go to public swimming pools, and there were all kinds of sort of myths about how you could get it. Anyway, this is, we have now tremendous technology that really started in the early 70s and late 60s the positive pressure ventilator, which you see in intensive care units. Intensive care units themselves, I graduated from medical school here in 1970, and the first intensive care units were opening up then. There were no intensive care units. And because of that, people are able to be kept alive a very long time. So this is actually a tombstone of one of the famous right-to-die cases that actually went before the Supreme Court. And this was Nancy Cruzan. And Nancy Cruzan was a young woman, was in a car accident and suffered an arrest, was resuscitated, but had severe brain damage. And she ended up in a persistent vegetative state. And she was born, so this tombstone is very interesting and poignant in many ways. She was born July 20th. The parents wrote that she departed on, how did that happen? Okay. So in 1983, she was in the accident and entered into a persistent vegetative state. Of course, they didn't know it was persistent at that time, but the parents, she was treated for a long time, and the parents really tried to see if she would recover, if they could do anything. And then they petitioned the hospital they asked the hospital to take out her feeding tube. And this was not common practice in those days, taking out feeding tubes. And the state of Missouri said, the hospital said no, the state of Missouri Supreme Court said no, and it eventually went to the Supreme Court. And the Supreme Court actually said no too, but they said it was sort of a qualified no, which is people do have a right to refuse treatment, including fluids and nutrition, but the state may set the standard of evidence. And you just heard about advance directives. Well, she didn't have a living will saying, I wouldn't, if I'm in a persistent vegetative state, I don't want fluids and nutrition artificially provided. So the state of Missouri said it had to be very specific like that. And the Supreme Court said states can decide for themselves. So this was a big national case. It was in the newspapers, it was on TV, people were discussing it a lot. And a couple months after this, her family found some evidence, and it was clear that the worm was turning in regard to this issue, and eventually the health professionals let her die, and that was on December 26, 1990. But you can see that this sort of captures a transition that is fairly common these days, that people who are caught in the jaws of technology, they get in and they don't escape. They don't either die or get better, have diminished qualities of life and loss of function, and still can be kept alive. And it began raising the question of when is a person really dead. I want to review with you for a minute, because we're going to talk about brain death, several states of severe neurological impairment that each has different ethical implications. And they often get confused by the lay press and actually even by physicians who don't deal with these things all the time. So, somebody want to tell me what persistent vegetative state is? You got a lecture about this? No? They're letting a psychiatrist tell you what persistent vegetative state is? Okay. So persistent vegetative state is what Nancy Cruzan had, and it's where you have severe damage in your cerebral hemispheres, but your brainstem is intact. So remember, the brainstem takes care of homeostasis, and it maintains and integrates the body, so temperature control, breathing, blood pressure, electrolyte balance, all that stuff is done through the brainstem. So consciousness is actually a dual function of the brain, of the upper brain, the cortex and the cerebral hemispheres, and the brainstem. So there's something in the brainstem called the reticular activating system, which sort of sends things to wake up the cortex, and the cortex is where consciousness is seated. You can't have one without the other. Some people have made an analogy, which I think is fairly good, to a light bulb, so that the cerebral hemispheres and consciousness and light are the function of the light bulb, but the reticular activating system is the electricity that lights up the light bulb. So if you have the electricity without the light bulb, you don't get light, consciousness, and if you have the, either one by itself doesn't do it. So people in PVS have intact brain stems, so they can breathe on their own. The support they need really is basic care. They have to be fed and given hydration, and they have to be turned so they don't develop bed sores because they can't move. But they can live that way for decades. And they're breathing on their own, and questions came up and have come up a lot about whether people want to be kept alive in that state. The other thing that's confusing about them is they have sleep-wake cycles. So you could say, well, how could a person who's not conscious be awake? And again, it has nothing to do with consciousness. It's a stimulation from the reticular activating system that makes people have sleep-wake cycles. So their eyes are open, they look like they're alert, but they're not. Nothing's happening. Or so we thought. Now there's something called the minimally conscious state. And it turns out that a certain number, very, very few, under 5%, of people reliably diagnosed in PVS have some degree of consciousness. And how did we find that out? We find that out by putting them in fMRI machines and asking them questions. Like the most famous study was done that said, imagine that you're at home walking around in the rooms of your house, and then a certain part of the brain lit up. And then they said, imagine that you're playing tennis, and another part of the brain lit up. And then they said, I'm going to ask you some questions, and if the answer is yes, imagine walking in your rooms, and if the answer is no, imagine playing tennis. And people were able to clearly answer those questions in a consistent, intelligent way. So that's pretty scary. So what are the ethical questions with somebody in PVS? Well, it's, in a way, is that a life worth keeping alive? And about 10 or 15% of the populations think it is, including 10% of 15% of physicians. But most people don't. And that's one of the things that's a good thing. Your chances of getting in PVS are very small, but if you don't want to be kept alive that way, tell your durable power of attorney and write it in your living will. It's an easily identified thing. Now, I haven't added it yet, but I'm going to add to my living will, and of course I'm not saying this is what you should do, but I think minimally conscious state, in my view, is worse than PVS. I don't want to be lying there thinking about things and feeling pain and not being able to express myself except when I'm in an fMRI machine and answering yes or no questions. And I would just as soon not be in that state. That's worse. At PVS, I'm not aware of anything. My reason for not wanting to be in PVS is that I don't want my family to either feel obligated to visit me or feel guilty for not visiting me. And I don't think it's a good use of resources. There's no point for me. Yes?
So if you're in that minimally conscious state and you don't have an advanced directive, could you answer a question regarding whether or not to remove care?
Well, this is a very good point. Could you? have such a conversation with a patient? Because it seems like it would be a pretty important conversation to have. And as far as I know, nobody's done it. These communications obviously take time, are very rudimentary. So first you'd really have to do a mental statics exam, wouldn't you? Because you wouldn't want to just ask somebody out of the blue, do you want to stay alive? You'd want to make sure they knew their diagnosis and prognosis, and that they were oriented, and that they, memory was good. And nobody's done that. And some people have written it would be cruel to ask them that question. I mean, to me, it's like, whoa, don't ask, don't tell. It's better not to know that people are there. The other thing is, what do you do? Do you say, well, it's nice knowing that you're there and awake, and we'll come back in a year and put you in an fMRI machine again and see if you're still awake or not, or conscious? Or do you say, we're going to spend millions of dollars putting you in an fMRI every day and having your family visit and be able to communicate with you? And it seems to me that once you know that there's somebody there, you can't just let them go back into that state. And so it raises a lot of impractical issues, or issues about impracticability. Another state is locked-in syndrome. Anybody know what that is? You're taking the neurology, and they didn't tell you what locked-in is? Yes.
It's like the deferring state, like a damage to the ventral pons, I think, knocks out.
Very good. Right, so there's usually an injury to the pons, and all the motor neurons come through there. So you become unable to move, talk, and you're fully conscious and aware. And people have been misdiagnosed as being in PVS, and they were locked in. It's not like minimally conscious. These people are fully conscious. Another one that's not a good, I mean, you go through medical school, you have a top 10 list of things you wouldn't want to be in, and it changes. The top 5 rarely change, but number 10 might change. For me, that's up there. That's in some ways one of the worst. Anyway, and what is anencephaly? Pardon? Yes, you don't have development of your cerebral hemispheres. You're basically born with just a brainstem. So you can breathe, you can suck, but you're never going to be conscious, and actually they're very unstable. And although some efforts have been made occasionally to treat them aggressively, but the normal practice with anencephaly is to keep them comfortable, feed them, and let them die of intercurrent infections. Let the parents hold the baby if they want to. It's interesting, if you go to Google Images and you look up anencephaly, the first 100 images or so are put up there by Right to Life groups who encourage people to adopt them or keep them alive. But the pictures are pretty grim, but so obviously if you spend money on Google, because I've looked at it before and that wasn't the way it was. So if you spend money, so obviously they spent a lot of money so that these people looking would get a positive message about the value of their lives. But the common practice is to allow them to die. Okay, now we're going to come to brain death.
Actually, I have a question.
Sure.
How would you rule out locked-in versus PVS?
Oh, I'm sorry. I left out a big thing there. Locked in almost always have some movement of something. Might be they can move their little finger. It might be that they can blink. And somebody notices that and then starts asking the yes or no questions. Does Cleveland blink once for yes, blink twice or no? Does Cleveland have a good professional football team? No, they blink twice. Yeah, if you blink 20 times, I know what that means. So yeah, well, so then they find out there's somebody home. And they can do fairly elaborate now with computer and stuff, if you're wealthy enough to afford it, so they can spell things and, yeah.
Do you differentiate them on like caloric testing, like being able to have this magnets?
Yeah, well, they wouldn't be their brain stems are intact, so they would not. We're going to talk about how you can flunk the brain death test, and that's one of the things. You test for cold calorics. Tell me what nerve it's probably going to be on your exam. What nerve? What cranial nerve? I don't know. I forgot. I knew it was. Okay, well, it's one of the cranial nerves. Put cold water in, and they get nystagmus. Put cold water in their ears. But no, they would not. They have that sign, positive. I don't know what positive means here. I mean, they don't have the deficit. Okay, so I'm going to tell you a story about defining death or measuring death. 95% of deaths take place the old way. And you're doctors, you're going to be doctors. What is the old way of telling that a person is dead? The way in 95% of cases. How do you tell a person is dead? Heart stops beating. Anything else? Stop breathing. Anything else? Right. Can't arouse them, can't communicate. Okay. How do you test for those things? Did you get a lecture about that? How did you know that? I'll bet you knew it before you came to medical school, right? You didn't learn that in medical school. And how do you test for those things? Okay. Well, it's interesting that you don't get a lecture about it, and that probably you learned it just like I learned it through movies and TV, right? I mean, duh, it's pretty obvious, and you see it. You see it in the culture. Everybody knows it. Well, my story is, there's an interesting phenomenon which I periodically, when I'm with a doctor, I'll say, tell me about the first time you declared death, when you were the person who was responsible for declaring death. And remember, it's a pretty big transition that you're proclaiming there. Living person, corpse. All those things that I showed you can take place once they're dead. A lot of things can't take place until they're dead. So I was a third-year student. This was in 1968. And I was on the surgical service, and I was covering the emergency room. And it was in November, and it was 3 o'clock in the morning. And the police, as they still do, brought in somebody they found on the street who they thought was dead. And they had what used to be called a paddy wagon, which was kind of a panel truck, where they did things like that, or if they arrested people, they put them in the back of the paddy wagon. Paddy because I think in New York and many other cities, the police were predominantly Irish. So this was called a paddy wagon. So they left the body in the paddy wagon, and the police came in and had coffee with the nurses who they knew well, and they're chatting. And they said, could you send somebody out to declare the patient dead? And the emergency room was very busy, and the surgical resident said, Youngner, go out and declare that patient dead. So, I'd never had a lecture about it, but I sort of knew what to do. So I go out and I get in the back of this paddy wagon. It's very, very dark in there, but there's enough light in the parking lot that I can see this guy as an old guy lying there, sort of looks dead. And I thought, okay, so what am I going to do? So I take a stethoscope. I take out the stethoscope and I listen to his chest, and I don't hear a heartbeat. And then I thought, sometimes when I make rounds in the hospital, the attending hears a murmur, and I don't hear it. So is it possible that this heart is beating very faintly and I don't hear it? Okay, I'll take a pulse. So I took a femoral pulse, I took a carotid pulse, I took a radial pulse. I didn't feel any, no pulse. And I thought, what if I'm missing it? I'm just new at this. I'm not I had this early clinical experience for me. Go back and listen to the heart again. So I go back and I'm listening to the heart and I hear, Younger, what the hell are you doing out there? And I jump out of the paddy wagon and I say, he's dead. So that's my story. Now, in the 1960s, we had positive pressure ventilators. So we often had people with catastrophic brain injuries. In the past, if you have a catastrophic brain injury, including the brainstem, what? You stop breathing, your blood pressure drops, your heart is going to stop pretty soon. The heart isn't dependent on the brain, right? Heart can function without the brain. You can take the heart out of one person and put it into another person, and you don't connect it to the brain. The brain can influence the heart, but the heart has its own internal pacemakers, right? And it can beat by itself. So traditionally, they all happened at once. If you stopped breathing, you lost consciousness. Your heart stopped pretty soon. If your heart stopped, you lost consciousness. You started breathing. So these are the three basic systems that are very interrelated, and we never really had to choose among them. But with the positive pressure ventilator in the intensive care unit, we now had a group of patients that we could put on a ventilator, and their brains weren't working. But we could maintain their hearts because we could pump oxygen through their lungs. We could, fill their lungs with oxygen, and with a positive pressure ventilator, the oxygen would circulate, and we could give them glucose, and we could correct acidosis, and we could really maintain them. And we never had, it created a new class of patients that never existed before. You couldn't exist without all that technology in that state. And in 1968, an ad hoc committee at Harvard said, boy, we have these patients, it's a new state, but we could be charged with homicide. Remember, this is 1968. We didn't have ventilators until then. So there was no law, no hospital guidelines, no professional guidelines, no public discussion about, is it okay to turn off a ventilator and let a person die? Is that killing? And it was sort of viewed as killing back then. And it still is in some countries in the world. So they realized they had these patients who were going nowhere. People don't recover from brain death. If you have a massive stroke and brain swelling, and then you herniate the brain through the foramen magnum, and all blood is choked off, you're not going to recover from that. Or if you have a shotgun blast and 3/4 of your brain is gone, you're not going to recover from that. But can we turn off the ventilator? And then that also happened that organ transplantation had just started at that point. The first organ transplant took place in Boston about that time, and it was identical twins. Live, they didn't have very good immunosuppression, and you obviously can't, we'll talk about the dead donor will kill somebody, but here you had identical twins, and so they did took one kidney from one twin and put it in the other. But look at these brain dead people. They're on a ventilator. All their organs are getting oxygenated, getting nutrients. The kidneys are producing urine. The lungs are exchanging air and oxygen. The liver is metabolizing and doing all the things that it does, and it does, as you know, many, many things. The pancreas is working. All these organs are working, and they make a great source for transplantation. Because you say, well, why didn't we just take them out of dead people? The reason you don't do that is what's called warm ischemia. So when somebody dies, cardiopulmonary arrest, there's a period where they're still warm, 98.6, 98.4, going down slowly. But because of that temperature, the tissues and the cells continue to metabolize. And it's like running an engine without gasoline. It's not very good for it. So the destruction is sped up by the warmth. So if somebody is dead, and you wait 20 minutes, half an hour to get the organs out, they're not going to be in very good shape. Here are patients where they're in great shape. So when you take organs from these people, people also have a misconception about this. How many people think that if you have a brain-dead patient on a ventilator, you're going to harvest the organs, the patient wants it, the family wants it, you take them to the operating room, do you turn off the ventilator and then get the organs, or do you keep the ventilator on while you're getting the organs? How many people think you turn it off first? Okay, very brave of you to raise your hands. You're wrong. But that's a common misperception. And I'll bet probably some of your classmates just weren't brave enough to raise their hands. But no, you stay on the ventilator till you got all the organs you want. But if there's something called the dead donor rule, which is, it's not a law, except that we have laws against homicide, that you can't kill somebody by taking their organs out. So when they wrote this paper, the reasons they gave, they said, let's say these people are dead. Let's call them dead. Let's classify them as dead, legally, medically, and everything. Why? To avoid the charge of homicide. So a philosopher would say this is like a utilitarian argument, and you're changing a category because of what you can get out of it, and that it's not logical. And they had no, if you ask the question, well, why are they dead? What makes this person dead and a person in PVS not dead? They didn't address that issue. And it wasn't until about 13 years later that the first sort of philosophical explanation of what makes them dead came out. So we went through these. The things in red, and I'm going to come back to this, is, remember what they said is we had to say they're dead because we'd be charged with homicide if we stopped their treatment or if we took their organs. And our society's had a very big discussion since then for over 40 years, and there's a pretty firm consensus, including Supreme Court decisions now, that says that people have a right to refuse treatment, including ventilators or fluids and nutrition or anything else. So you don't have to be dead to have treatment stop. But you still have to be dead for removing organs. And is that a good idea, or is that not a good idea? So, now we're going to do two things here. I'm going to tell you some facts that you should know as physicians. Yeah?
You don't have to be dead to pull it.
Well, if it's a live donor, then, but yeah, live donor, very good. Yeah, so if you give one kidney, part of a liver, part of a pancreas, one lung, that's not killing the patient, so it's not a violation of the dead donor rule. So the things that you need to know as physicians to function is that brain death is legally death in every state in the Union. I'm going to tell you why brain death is a very flawed concept, clinically as well as philosophically. However, it is the law, and it works okay. Usually people accept it. They don't always accept it. There have been some stories recently where families didn't accept the diagnosis of brain death. And actually in New Jersey and New York, because they had large Orthodox Jewish populations that did not accept brain death, they thought that the last breath was when you died. There's an exception. So if somebody wants to say they don't believe that brain death is death for religious reasons, they're not dead in those two states. So here are the facts. There are clinical criteria for diagnosing brain death. Very reliable criteria. No brainstem reflexes and no response, just like in PVS, or no response. They don't talk, they don't respond to painful stimuli. And then all the brainstem reflexes, not all, but they try to go from the top of the brainstem to the bottom to make sure that there's destruction all along the brainstem. And I can't, you guys should probably know this exactly, what nerves and where they come out. Might be on your test. So these are they actually take them off the ventilator for a brief period of time to see if that triggers efforts to breathe, which would show that the reticular activating system is still intact. So these are things that are, you could probably learn how to do them reasonably well. The cold calorics is also in here. I didn't list it. Oh yeah, there it is, movements with calorics. You could learn how to do these things pretty easily. It's not like rocket science. They can be done at the bedside. And it has to be irreversible. So the definition of death and the laws around death, and I'll show you the law in Ohio, all say that the function lost has to be irreversibly lost. And so in brain death, you can have clinical conditions that mimic brain death, but that are reversible. And one of them is the presence of intoxicating drugs or sedation. So I saw a case once I was asked to see after the person woke up, and a 16-year-old boy had taken a massive overdose of barbiturates and came in a deep coma and looked as if he was brain dead. He flunked all the brain death tests. But he had barbiturates in his system, so it was potentially reversible. So you couldn't call him dead. They didn't call him dead. They waited a couple days and washed out the barbiturates, and he woke up and got to get interviewed by me as a psychiatrist. And I know his mother, and he's like 55 years old now, getting married next week. So, I mean, he really made it. So thank goodness that we didn't say he was dead. Absent hypothermia is another one. You fish somebody out of a cold lake. You have to warm them up before you can say that they're brain dead. And no neuromuscular blockade. And reproducible clinical testing. So just about everywhere now you have to go through these tests twice. It used to be more conservative, 2 days apart, 1 day apart. Now it's 4 hours apart, 2 hours apart. And there's been some criticism. Somebody did a study recently, and hospitals all over the country do it in completely different ways, have completely different rules for this, which could be a little bit disturbing. If you said, well, you could be dead in this hospital but not in this hospital, and what does that mean? Why was brain death accepted so quickly? It was accepted quickly in the United States. It was enacted into law and accepted by the medical community within a few years, 2-3 years. You say, well, of course, we're an advanced medical society. We're very intelligent. Of course that we would do this. But it's interesting that in Japan, which is an equally wealthy, sophisticated, medically sophisticated country, brain death has not been accepted. So they do very few. First of all, it was against the law. Then they had a national debate that lasted a couple decades, And finally, they have a law that you're dead, you're brain dead, if your family has signed papers and you have a living will saying you want to give organs. But if you're not an organ donor, then you're not dead. And they get very few organs that way. They have a huge number of organs from live donors and from what are called non-heart beating donors, which we may or may not have a chance to talk about. So why was it accepted so quickly in the United States? One, it's a 100% reliable diagnosis. People who are diagnosed with brain death don't wake up 10 years later or 5 years later or 2 weeks later. They just don't. Second, so the diagnosis and prognosis. Patient will never wake up, and at that time, back when they first started talking about brain death and diagnosing it, they were very unstable. These patients had to have very, very active, aggressive care in the intensive care unit to maintain their blood pressure and temperature control and electrolyte balance were all screwed up because the brainstem regulated those things. So they had to be done by the hospital staff. And as we'll see, that's not true anymore. This one is not true anymore. And of course, quality of life, it's even worse than PVS in some ways because you're attached to a ventilator, not just getting feeding. Okay. And they were an excellent source of organs. That was part of it from the beginning. Many people, myself included, think that's what motivated brain death. We wouldn't have it if it wasn't for that. We don't need it. We don't need it to turn off. You don't have to say somebody's dead to turn off a ventilator. Okay, here's the law. And this is uniform laws. There's an organization, I think it's affiliated with the government, that when there's a new problem that comes out, they'll write a law as a model for the states, and the states can adopt it or not adopt it. So it's not a federal law, but they're state laws. And this is what they recommended, and Ohio has something almost exactly like this. And so you can be dead in two different ways. You can be dead by irreversible loss of circulatory and respiratory functions or loss of functions of the entire brain. The problem with this is, well, I'll look at this. How do you, in normal circumstances, does it matter if you're dead at point A or 5 minutes later or 20 minutes later? What difference does it make? It doesn't make any difference. What matters is that you're dead. But the exact time doesn't matter. But with organ transplantation, it's important to have an exact time because you want to get the organs out before they're damaged. And this is particularly true with non-heart beating donors. People know what non-heart beating donors are? So this was a new way of getting organs because brain death wasn't doing the trick. So there's a huge shortage of organs. So non-heart beating donors is where somebody has a brain injury, but it's not brain death. And it's affected their respiratory center enough that they can't breathe and they're on a ventilator. But they're also, let's say half their brain is blown away, but they have a gag reflex. They can't be called dead. But their prognosis is terrible, and the family says, stop, turn off the ventilator. They're just going to stay in the intensive care unit and die in here, and we don't want that. Well, now, if you do that, there are protocols, and all the hospitals in Cleveland have them, is that you take the patient to the operating room, and there you turn off the ventilator. But before you turn off the ventilator, you prep the person for surgery. And you turn off the ventilator, and let's say that you were right, that they couldn't breathe on their own. Sometimes that's not right. Most of the time it's right. And they stop breathing. But the heart doesn't stop right then, right? So they'll wait for a certain period of time for the heart to stop. Then the heart stops. And here, remember, the definition of death in the law is a functional definition, the functions of the brain, the functions of the cardiovascular system. Not that your heart has to be dead itself or your brain has to be all dead itself. It's the functions that have to be gone. So the heart can stop pumping blood and still be alive. For instance, ventricular fibrillation. And what they measure in these protocols, they put a femoral artery catheter in, and they measure whether there's any pulse. And when the pulse is gone, they say that cardiac function is lost, which makes sense. But it could be somebody in ventricular fibrillation. And if you put paddles on, you could get the heart to start beating again. Now, albeit it's not getting oxygen, so it's only going to beat for a very short time, but you could get it to go again. So what does irreversible mean here? And there's data that shows that after 2 minutes in these protocols, the heart will not auto-resuscitate. It won't start beating again by itself. So if you wait 2 minutes, that won't happen. And however, you could wait 10 minutes and restart it by putting paddles on. So the transplant surgeons didn't like that because you have more warm ischemic damage. So they've opted for saying it's irreversible at 2 minutes. And they say, well, what does irreversible mean? Well, what does irreversible mean? They say it means we've made a moral decision not to start it again. And opponents of that say that's not what it means. It means we can't start it again. Is there a right answer to that question? Can you look it up in the dictionary, in a law book, in a medical book? No. Just something we never had to think about before because nothing hinged on it. But here it does. So let me just show you this diagram. So let's say a man is walking down the street and he falls to the street, loses consciousness, and that's time 1. 5 minutes later, I walk by, time 2, and I see him lying there, and I take out my stethoscope. Now that I'm finished medical school, did a residency, I'm much more confident, and I listen, and there's no heartbeat, there's no pulse, and he's not breathing, and I found out that these functions have stopped. I start resuscitation. I start pounding on his chest. I have somebody call 911. 5 minutes later, they're there. They take it over. They take him to the emergency room. And after half an hour, they say, it didn't start again. We can't get it. It's irreversible. But they're just saying that after 30 minutes. I mean, it could have been after 10 minutes. It could have been after 20 minutes. So at some time that they don't know, it became irreversible. And then they said it's irreversible. So my question to you is, which one of these times did the patient die? And we don't have time for me to go around the room, but in fact, there's not an answer to that. The organ transplant people want it as close to when they find out the function. So here, time 2, when they're monitored in the operating room, T1 and T2 become the same thing. So then the question is, when does it become irreversible? And then there's this problem with irreversible. I'm going to tell you one other thing that's interesting, and that is the philosophical justification for brain death that came out 13 years after brain death was accepted is that what makes so the philosophical question is, what function is so important that when it is lost and all the other functions remain, the person is dead? Again, a problem presented by the intensive care unit. We never had it before. And the answer that they came up with was the integrating function of the brainstem. That the brainstem integrates the functions of the body, and without that, that's the essence of what life is. I won't go. There are a lot of zillions of papers written about this, criticizing it, a few defending it. But it turns out that, remember I said that it was accepted because very soon, within hours or days, there would be cardiovascular collapse and traditional death. It turns out that's not always true. They we said, what motivation could you have for continuing to treat such a person? The motivation was that cases came in of women in the early stages of pregnancy who were brain dead. And the baby was too young, the fetus was too young and immature to live outside the mother. So the families would say, keep her going and let the baby gestate until we can take the baby from the mother, either through inducing labor or C-section, and then then turn off the ventilator on the mother. And so they tried harder. They had a reason to try, and they were able. And this isn't myth, urban myth. There are plenty of papers in the literature documenting series of cases of this. I saw one at university hospitals about 25 years ago. They can keep them going for months. The case I saw is an 18-year-old girl who started having bad headaches and actually said, something's wrong. If I die, save the baby. She was, 7 weeks pregnant, something like that. And then she had a ruptured aneurysm. Brought her into the emergency room. And the family, here you actually had the patient saying she wanted it, but the family wanted it. So they kept her there for 3 months. And, her hair grew and her nails grew. They had to trim her nails, and she had good color, and the baby's growing. That doesn't mean she's alive, but it's not dead like other people are dead. And I'm sure most of you, and you don't raise your hands if you don't agree with this, most of you would probably be uncomfortable dissecting such a dead patient. Although for a surgeon, it would be a much better learning exercise than dissecting a cadaver. So if they're dead, they're not exactly dead like other people. Or should medical students go in and do rectal exams and vaginal exams on these patients because it's more like, real people than not, and we're wasting a real training exercise. So far, that hasn't happened. Although there are now experiments being done on brain dead patients in a couple centers, experiments that couldn't be done on living people. Okay. There are now cases reported of people who were reliably diagnosed as brain dead who were kept going, I'll put alive in quotes, for 20 years. 20 years. 4-year-old, the most famous case, 4-year-old boy who was diagnosed as brain dead. A neurologist who wrote the first series of these prolonged somatic survivals went and examined him, looked at his medical records, and said the diagnosis was accurate. And this kid lived to be 22. He grew. He was home on a ventilator and artificial feeding. His mother took care of him at home. So everybody said, oh, this guy's a quack. The patient wasn't really brain dead. They did an autopsy of the brain after he died. And it wasn't done by the guy who wrote the paper. It was done by an independent pathologist who wrote up the case. The brain was the size of a fist, and there was no living tissue, and it was completely calcified. So he was brain dead. Now, I'm just saying that intuitively or phenomenologically, they're certainly not like other dead patients. So I'm going to finish up here. The dead donor rule says patients can't be killed in order to remove their organs or by removing their organs. I'm going to just go to my end here. So I'm going to argue that the moment of death is a social construct. We never had to have, there is such a thing as death, but we never had to say exactly when it occurred because it all happened at once. And now we have to draw a line someplace. And I think the analogy of the strike zone is a good one in a couple ways. So I gave a talk in Spain about this, and nobody knew what the hell baseball was. So I had to explain it to them, and they liked it. So I thought, yeah, I won't even ask who doesn't know what baseball is here, because that would be too embarrassing. But so let me go back one here. This ball is coming at, maybe 100 miles an hour sometimes. And what the umpire, who's standing here behind the batter, has to do is say whether it's in the strike zone. Right? So this ball is moving 100 miles an hour. It may be curving. And there's a strike zone that's been prescribed by professional baseball. And it's interesting because that's socially constructed, too. I mean, that's not a fact of nature. And you know that it's manipulated. There have been years where too many home runs were being hit, so they made the strike zone bigger, or that not enough hits were being made. It was low scoring, so they made it smaller, so it was harder for pitchers and easier for batters. And so it's been manipulated to serve other useful purposes. So the definition of death is a little bit like the story of the umpire. So here's the story. A kid goes to a baseball game with her father. She's never been to a game before. They watch the game, and she says, "Dad, how do the umpires tell what's a ball and what's a strike?" And he says, "Well, after the game, let's go talk to them." So they go to the first umpire and ask him, and he says, "I call them as I see them." The second umpire says, "I call them as they are." And the third umpire says, "They are nothing until I call them." So death is a little bit, the moment of death is a little bit like that. I think we all, you could say, well, there's no such thing as death. Well, that's silly. It's so counterintuitive. We all know there are things that are alive. Let's say you have a 4-year-old boy on a swing, completely healthy, singing songs with his mother while she's pushing him on the swing. Anybody want to say he's dead? No. Napoleon. Anybody want to say he's alive? I didn't pick Elvis, you know this. So he's dead. But in 1968, we had this class of patients that we now call brain dead. They were clearly alive, according to medical standards and the law, but in some ways they were more dead. You can say, you're either alive or you're dead. Yeah, but you can be closer to death in time, right? I mean, this person's going to die. Well, we thought so then, very soon. This little boy isn't. This quality of life is full. This quality of life, a lot of the things that living people have are gone. So clearly they're nearer to death in a real sense. But they're not dead. And if you take their organs, you're killing them. Okay, well, guess what? The Harvard Committee said they're dead. No problem. So I think my view is that the integrating argument is very weak. There are very few people who look into this who aren't neurologists or neurosurgeons who are upset that somebody's saying that what they say isn't right. But conceptually, I mean, they've been the controllers. They've been the umpires. And they don't like a bunch of philosophers coming around and telling them that they're, or other physicians and telling them that their criteria are bad. By the way, what happens? Why did these people stay alive for so long after their brainstem is gone? Well, it turns out that other parts of the body can take over integration. For example, there are baroreceptors in the great vessels that can control blood pressure. And it turns out that really a lot of the functions, the temperature control. This mother took care of this kid. She didn't have blankets. She didn't have, she wasn't giving him electrolytes and checking his blood all the time like you have to the first few days when somebody's brain dead. So what does that lead to? It's tough to talk about this in public, and this is a great Gary Larson cartoon. I don't know if you can read the letters, but this is hospitals to avoid, and you can see the signs that room, deader than a doornail, about as dead as a doornail, anyway. So what does it mean? So the take-home message that I would give you is, don't worry if you are working in a hospital and you follow the protocols and declare somebody dead according to neurological criteria, or the protocols for non-heart-beating donors. You're not doing something illegal, and I don't think immoral, because all these things, the person wanted it. Whether they're really dead or just as good as dead is the issue. And we have been able to have a social discussion about when it's okay to turn off a ventilator, even though a person isn't dead. We're not harming them. They want it. What's wrong if somebody's brain dead, saying they're beyond harm, they want this? What difference does it make if we speed up their death? Oh, but you're killing them. Okay, well, is that worse than pretending you're not killing them by gerrymandering the line between life and death? So that's an intellectual exercise, but don't worry about it in the clinical setting. And somebody asked me once, well, would you say that to a family you were talking to and explaining why their brain-dead loved one is dead? I probably wouldn't. I'd probably pull my punches on that one. And I'd say something like, they're legally dead, they're medically dead by every criteria. And if they said, but Dr. Younger, what do you personally believe? I'd say, that's really not relevant. But fortunately, I don't talk to those families about this. So, okay.
Hi, everybody. There are all of these views from all the content areas. Today was bioethics. There's also orthopedics, neurology, and psychiatry. We have 2 neuroanatomy reviews also, and I had suggested doing one on neurotransmission and that kind of molecular stuff. And if you want it, raise your hand. Oh man. Okay.
Okay, boy. That's good.
Okay, I'll do it. Okay, I'll do it. Yeah, thanks very much. Good, thank you. And there's a review that feedback session.
Gary, do you remember Gary Larson?
Oh, yeah, I love Gary
He's
Larson.
so great. Oh, my God. What a cartoonist.
About decision-making in patients with dementia.
Say that again?
I have a question about decision-making and capacity with
Yes,
patients with dementia.
sure.
So if you have some sort of like dementia, like frontotemporal, where your personality is undergoing like rapid changes, how do you sort of like, who gets to make that decision? Like, is it like the old you that, if the old you makes a living will, and the new you with like these personality changes, all of a sudden doesn't want like basic treatments?
But,
like, how do you decide?
but they can understand what's going on.
Yeah, but they can understand what's
Well,
going on,
that's-
but they're just like
They're disinhibited and so,
right?
yeah.
Or
well,
like an Alzheimer's patient who's like undergoing like daily
Well,
fluctuations.
I think the gold standard is to go with the current patient, but I can see if they're distorted,
You'd probably
it
get a
gets really
surrogate
tricky.
involved.
Yes.
You try to talk to family. I mean, you try to do it's murky.
Yeah.
I think they would try to figure out what this person's quote-unquote autonomous wishes were, and different people would probably count or discount the